So we'll go to the third in the series presentation, anterior segment OCT in congenital corneal opacity, being presented by Sonam, Dr. Sonam Yangzes.
Yes. Very good morning, everyone. I'm going to present anterior segment OCT in congenital corneal opacities. So congenital corneal opacities are basically very heterogeneically heterogeneous group of disorders, and early diagnosis is essential in such cases because of deep vision deprivation amblyopia, and measurement of the corneal thickness plays an important role in both diagnostic therapeutic assessments, because majority of these kids have glaucoma as well, and various tools are available with us. And ultrasound pachymetry is a standard in measuring the corneal thickness, but it's a contact procedure and perpendicularity of the probe is essential. And swept-source AIOCMT3 is nowadays more frequently used in babies as well, and it's a non-invasive, non-contact and a fast method. There are various studies which had compared AIOCMT3 with that of ultrasound biomicroscopy for assessment of the anterior segment, and they have found that the earliest study published back in 2007 found that in clear corneas, they are quite comparable. But in corneal opacity, there are studies which show that there's a variable correlation or interchangeability between these two modalities. This is a recently published article from our department itself, where we found that the AIOCMT does provide preliminary data, and it can help us in diagnosing at an early stage, but UVM remains the gold standard. So our objective was to determine the interchangeability of the pachymetry measures by AIOCMT with that of the UVM. So it was a comparative consecutive case series of children which were enrolled over a period of 2 years and less than 5 years of age. And mainly we discussed the pachymetry, we studied the pachymetry. Just a small video to show how we measured the swept source, or how we did the swept source OCT in children after proparacaine instillation. Flying baby technique was used to stabilize the head and the neck of the patient. And then because it does not require any fixation, incidental fixation is fine, so we got the images. So in order to measure the pachymetry measurements, we took the scleral spur to scleral spur distance, and the central corneal thickness was measured. AIOCMT has this technology inbuilt, but for UVM we overlap the images between the UVM and the OCT to get the central area, like in this image. But the cases which had severe anterior segment dysgenesis, where the sulcus anatomy was distorted, both the images were overlapped together, and the centralmost area was assessed for measuring the CCT. So 54 eyes of 36 patients were imaged using both UVM and AIOCMT, and females were more common, and the age group varied from 11 days to 5 years. So we found that the mean pachymetry of UVM was higher compared to that of the AIOCMT, which was slightly different from the previous studies, maybe because the previous studies were done in adults without any anterior segment dysgenesis. So here, this image also shows the same thing. And the difference in the pachymetry between UVM and AIOCMT was statistically significant. Then here on this scatter plot, we can see there are multiple outliers because of the variable corneal thicknesses, and blind Allman plot showed that there was no interchangeability between these two imaging modalities. Just a few examples, like here we can see that this is a case of type 1 Peters anomaly, where UVM has shown 680 microns as the thickness, while AIOCMT is showing 651. But if you go slightly, maybe like 2 millimeters away from the central cornea, then the thickness is 410 microns. So just slight change in the central corneal causes a huge variation in the CCT. While in this case here you can see there's a thick retrocorneal membrane, where in the UVM there is no delineation between the cornea as well as the membrane because of the poor resolution, you can see, because it appears uniformly hyperechoic, while on the AIOCMT the retrocorneal membrane is very beautifully delineated, which can help us in measuring the corneal thickness better. Of course, the study had limitations because of lack of centration while doing UVM as well as OCT. Manual measurement was done for UVM, so observant bias is present, and those tissues, corneas which had stromal excavation, side-to-side variability was high. Even though the sample size is high, but it's one of the largest studies so far with the maximum number of patients with congenital corneal opacity. But there was a lack of control group of children, age match controls. So I would like to conclude by saying that AIOCMT and UVM correlate well in majority of the cases, but pachymetry values are not interchangeable. Retrocorneal membranes were better delineated on AIOCMT owing to a better resolution, so we may rely on it better for a corneal thickness measurement. And the eyes with posterior corneal excavation, like in Peters anomaly, may affect the accurate pachymetry measurements. UBM still is the modality of choice as it penetrates better in cases, especially in cases with retrocorneal membranes and dense lenticular adhesions. Thank you.
Excellent, very good presentation, Sonam. Sonam, my question is that you said that you included consecutive cases. So there were no cases that you needed to exclude, or?
Ma'am, all those children who who were diagnosed with bilateral or unilateral congenital corneal opacities, and those who did not have, yes, we did exclude patients who had retinal detachment, associated retinal anomalies like FEVR, ROPs, stage 5, 4, 5 ROPs, ma'am. Other than that, those who had only anterior segment involvement, all the children were included. We did exclude children who had history of nutritional causes like vitamin A deficiency, infectious causes. After ruling those out, ma'am, then other cases were included.
So those, why did you exclude
also.
those cases?
Because, ma'am, the external factors, the acquired factors will affect their morphology of the cases, and we wanted to focus on children with specifically on corneal opacities which are present congenitally or since birth, ma'am. We didn't want to have any bias based on the acquired cause like scarring and all will lead to excessively thin corneas in such children, and we wanted to look at the cases which were totally naive otherwise.
So based on your study, which is the one indication where you think OCT wins over UBM?
Ma'am, now we are routinely doing OCTs in every single child, and we have now realized, ma'am, that just on unpublished data that up to 30 to 35% of the cases, ma'am, the children sometimes never get fit for a UBM for a pediatric examination and anesthesia. And even in those children, ma'am, we were able to make the diagnosis. At the same time, we could refer the patient with more information to the geneticist. And we are able to diagnose various anomalies as well as systemic as well as like syndromic associations because of our OCT, ma'am. So it does provide us a lot of information. Now it has been included as a part of the routine protocol for all children, ma'am.